My name is Dr. Barry Bittman, and I'm the Chief Population Health and Quality Officer for the Inland Empire Foundation for Medical Care. And I'd like to thank all of you for making time to be with us today on our presentation focused on Telehealth Annual Wellness Visits. I'd like to begin by thanking Dolores Green and her team at RCMA for their tireless work in providing information and education to keep our providers, our practices, and our patients healthy. I'd also like to thank my presentation partner, Mitzi Young. She's an RCMA, CMA physician advocate. I'd like to tell all of you that this program is being recorded, so you can actually listen to this later. And also that you can get a copy of this presentation on www.rcma.docs. I will show you that link toward the end of the presentation as well. There's a wealth of information on the COVID national health emergency on that site. So I'd like to begin today by sharing some rather important information in the context of where we need to be with telehealth annual wellness visits. Many of you have heard our presentations previously. A lot has changed over the course of the last 3 months. Many practices were quite reticent to use telehealth at all, yet it seems like the stars aligned. CMS and health plans made accommodations so that the payments are now on par, for the most part, with face-to-face visits, coupled with relaxed HIPAA regulations. The ability to use programs like FaceTime made it a lot easier. And most importantly, newly discovered efficiencies that practices are relaying to me from all over the country. I can tell you that I speak to physicians every day, and their comments are more or less uniform, that by doing telehealth, we're reaching more people. We're not dealing with cancellations and no-shows, and we find that this is an efficient, effective way of caring for many patients. Obviously not everyone, but for a subset of individuals. In fact, most healthcare providers are telling me that they hope that the regs, for the most part, stay in place so that they can continue this at the end of the national health emergency. Our objective today is really to focus on one area, and that's the annual wellness visit. Some of you are familiar with it. Some of you provide these services routinely for your patients, and for others, this might be something new, but there is a method to the madness here, and I'm going to show you how this can be extraordinarily beneficial during this challenging period. The annual wellness visit, as many of you may know, is basically prevention focused. It's provided by Medicare without a copay or deductible. This varies considerably with other health plans. The annual wellness visit has been described as a means for building a relationship and an understanding. And from a reasonable vantage point, it's also set up to level the playing field between the physician and the patient so that we understand exactly where our patients are along the health continuum. The goal of the annual wellness visit is really to uncover risks that were unknown to us before, close care gaps, and take the opportunity to provide education and guidance for improving health and well-being. What's really important over here is that this has become a staple strategy within ACOs across the country. And in ours, the Foundation Accountable Care Network in this region, we did some data analytics, and we actually found that patients who had annual wellness visits had dramatic reductions in their overall annual expenditures compared to those who didn't. Now, there may be multiple reasons for this. However, we are very strong supporters of the annual wellness visit. What are some of the additional benefits? Well, obviously, it's a great chance for us to document chronic conditions. As you know, RAF scores play an important role in reimbursement. It obviously improves engagement, and even more importantly than that, adherence. Sometimes it's really difficult to connect a patient with what you're trying to do, and here's an opportunity to lay that out in very clear terms. It can help foster earlier diagnoses, and it can also help us uncover diagnoses that were established previously by other practitioners or other providers in other areas. And that's where looking at those RAF scores comes into play. It identifies patients who are at risk or with psychosocial needs who could benefit from care coordination strategies. It certainly improves quality measure reporting because there's the opportunity to sort of lay out your plan for the year and figure out really what has to be done with that individual. And most importantly, it improves patient outcomes. However, there's a benefit that very few people are aware of at this time. As I speak to practices around the country and in our area, it becomes apparent that many practices have laid a number of staff off, they're furloughed, and that volumes have diminished considerably because patients don't want to come into the office. That's really not surprising. However, there may be a silver lining in all of this, and that is that performing annual wellness visits on your practice system-wide, meaning you take a look at your entire cohort of individuals, of patients, you determine which ones are at risk or have chronic conditions, you offer telehealth. That's a phenomenal way of bringing some of your staff back. And not to say the least, but annual wellness visits typically pay 3 times of what you would get for an office visit. So the beauty of it right now is that you can perform these via telehealth. You can organize the year of care or treatment for your patient, and you can get the remuneration that you need in order to be able to bring people back into your practice, I mean staff, that you may have furloughed previously. This slide basically differentiates 3 things. The first is the initial preventive physical examination. And this is covered once, only once. And this is within 1 year of enrollment in Part B Medicare. The patient pays nothing if the provider accepts assignment. This, however, is not acceptable through telehealth. Now, I want to emphasize this because this is a comprehensive physical examination. The second category is the annual wellness visit, and this is covered once every 12 months, and the patient pays nothing. So this is an opportunity to bring people in and to be able to provide this level of care. And by the way, on the day that you provide the annual wellness visit, you can couple it with other services if needed. And finally, I want to emphasize that what old docs like myself used to consider the routine physical examination, and this is stated in Section 90 by Medicare, this is not paid for. So the patient has to pay 100% out of pocket for a routine physical examination. Now, if it's tied to treatment or a diagnosis for a specific problem, then this is a covered service. With that, I'm going to turn this over to my colleague, Mitzi, who's going to provide some key information that'll help you get started.
Thank you so much, Dr. Bittman. Hi, everybody. Thanks for joining us today. My name is Mitzi Young. I am the physician advocate for the California Medical Association and the Riverside County Medical Association. So really what I am to all of you that are members, I am your private consultant for practice management. So make sure that you're using those benefits, and we'll get into that a little bit later. So let's kind of take a look here at the preliminary considerations. So again, this presentation, we're assuming that the practice is already performing, annual wellness visits. And if you're not doing that and you want to get started to doing it, we certainly have an amazing team of people that can help guide you through that. As noted in the prior webinars, we want to make sure that everybody understands that it's not a one-size-fits-all in any practice. So we really want to make sure that we're looking at things like your practice's existing annual wellness protocols, evaluation tools, and forms. So if that's something that you want to go over, kind of just take a look and see, we're going to be doing things a little bit different on the telehealth annual wellness visit than you did on your in-person. So I always like to tell everybody that options are really, really fantastic right now for patients. It lets them have a little control in a really uncontrollable environment that we're living in. So those in-person and telehealth annual wellness visit gives them that. And so we want to make sure you set up everything in your practice so that it's super successful either way, right? So it's in person or on your telehealth. You also want to, any changes that are determined by the nature of the remote visit, you want to make sure that you're looking at those pieces of the appointment. Your health plan documentation guidelines, super important. So here's what I tell folks: if you really want to get good documentation guidelines, go to Medicare. They have got a booklet on documentation guidelines, super easy to follow, and you can really help train the whole office, including physicians with that. And then also, you just want to make sure that you are checking with your health plans on their documentation process in accordance with it, okay? So your established patients, those kinds of things. So again, you need any help with this, don't hesitate to give us a call. Next slide. So our next slide is just your annual wellness visit components. I think that there are some really great tools also on Medicare that can kind of break this down for you. I'm going to do it a little bit right now. I'm going to go through it pretty quickly because we don't want to take a lot of time going through each one of them. But this is also, this presentation is really great. I will send this out to everybody. I should preface that. I will look for an email from Mitzi Young. It's going to come straight from me. I'm going to give the presentation to you after I'm done with this webinar. And then what we'll do is, you can certainly keep any of these slides and help for training tools for your practice. So that's why they're set up this way, is they're really super great training tools for the folks that couldn't come on to the webinar. Next slide. So when we kind of take a look at this, I really love these two slides that I'm going to show you. Dr. Bittman was nice enough to do them for me, and they are really in a very simplified form to the way to look at what you were traditionally doing in your office versus the telehealth. And so if we kind of look at the health risk assessment, it used to be done obviously via the portal or form-based prior or during the evaluation. That's something that now can be done via the phone by a designated practice staff, if that's how you guys want to work it out. Some of the things that I like to give to you is you're going to see a lot of synonyms through this presentation. So part of the health risk assessment is going to be your ADL, which is your activities of daily living, bathing, dressing, eating, or your IADL, which is your instrumental activities of daily living, cooking, shopping, managing finances. So I really want to make sure that you guys kind of understand that if anybody on the webinar doesn't. So that's how it's going to be done, traditional versus your telehealth. Obviously, your current medical and family history, there's going to be no change there. The medication reconciliation, you're just going to go over as you did before. Make sure, again, you want to put nice protocols in place for your policies and procedures for doing telehealth annual wellness visits, so that you make sure that you do all of the prep work before the actual telehealth visit happens. This is where this would come into play. You want to make sure that the patient knows to have all that information ready for the telehealth visit. And a list of anything that they need to have ready for the telehealth visit is good to put in your package. Your patient's current providers and suppliers, again, they'll prepare the list for you. That's easy. The history of the opioid use and other pain therapies. Obviously, resources may be limited during the national health emergency, and so you might go on and do a dedicated E&M visit if that's what you want to do, and there'll need to be a modifier attached to that, and we'll talk about that a little bit later. Your height, weight, and vital signs. This is something that's really important. So if your patient can self-report, if they have the tools, they have the cuff, right? Obviously a thermometer. They can actually give this information to you, and you can log that in with your annual wellness visit. But you can also have them come into the office at a later time and have that done then too. So there won't be audits right now, and I'm going to talk a little bit about that later as well, during the NHE, the National Health Emergency. So there are some really great forms online and practice tools. And again, if you are spending more than, say, a half an hour trying to find anything, I want to tell you guys, please reach out to us. That's what we're here for. Just call us and we can give that information to you. Next slide. So again, we're just
Mitzi, before we go to the next slide, just one comment. In terms of documentation, this is really key for Medicare. You can document self-reported by patient, or you can actually document unable to obtain due to COVID-19 national health emergency. And if you document it that way, CMS or Medicare will pay you for that service.
Thank you, Dr. Bittman. Great information there. So on our cognitive impairment, again, under normal circumstances, they would do the MMSE and the TICS. You can do that via the telephone, obviously now for your telehealth visit. Your depression screenings, which is going to be your PHQs and your BDIs, patient health questionnaires, your Beck depression inventory, or your geriatric depression scale. Those kinds of questions you can actually, they're filled out under normal circumstances by the patients. And so, you know, those screenings, or they're done by the staff, whichever you need to do. Again, options are important. So we just want to make sure that we're putting those internal policies and the practice in place on how you're going to do it so that you can make sure that the patients understand that, right? So your balance gait and risk fall, obviously you would be doing that, you know, in a timed up and go, or your tug, if you will, the tug test. You can do that via the telehealth if you have they have a support patient with them, and that you can, you know, obviously see them. So your screenings for, you know, your alcohol and tobacco abuse, substance abuse, you know, your structured screening treatments and or referral resources may be limited. Again, there's some really great sources online that we have put on here that I can help you find. If you can't find them yourself, just let me know. Your personalized prevention plan, discuss and provide to the patient at the end of the visit. So you're just gonna make sure that you wrap up your visit and consider postponing the preventive services like your mammograms, your prostate screenings, and you should, you know, obviously do your immunizations. Your advanced care planning, discuss and document is what you normally would do. Engage the patient when applicable in a pulse discussion, which is your physician orders for life-sustaining treatment. And so I think that you can certainly have them have a pulse form filled out. Just know that the pulse completion is always voluntary for the patient. Next slide. Sorry. Okay. My computer's not doing what I want it to do. Okay, so let's talk a little bit about the coding. So if you don't know, I think, you know, Dr. Bittman has said, again, Medicare will pay for this. They are going to cover the annual wellness visits for all beneficiaries who are no longer within the 12 months after the eligibility date for their first Medicare Part B period, and who have not had either an IPPE or an AWV within the past 12 months. Medicare pays for only one first AWV per beneficiary per lifetime and on one subsequent per year thereafter. So you must report a diagnosis code, obviously, when submitting the claim. And since you are not required to document the specific diagnosis code for the AWV with Medicare, you may choose any diagnosis code consistent with the beneficiary's exam. So here's what's really important. If you're going to do a separate identifiable medically necessary E&M service along with your AWV, Medicare may pay for the additional service. So report the additional current CPT code with modifier 25. And that portion of the visit may be medically necessary to treat the beneficiary's illness. So just make sure that if you do that, you just attach your modifier 25. Medicare has 2 HCPCS codes for these wellness visits, obviously the G438 and the G0439, and the G0402 known as Medicare Welcome Visit. And so you want to just make sure that you familiar yourself with this and that you understand how this coding is done for Medicare. And then next slide. So again, our beneficiaries provided vital signs sufficient to satisfy the portion of the annual wellness visit. Yes, if the beneficiary is at home and has access to that type of equipment, they would need to self-report vital signs, obviously your weight and your blood pressure, that type of thing. And if the visit meets all the requirements of the code, this scenario could satisfy the requirements of billing for the AWV code. So I'm going to give you a little extras on this. So that's Medicare. So we know that IEHP is also allowing an annual wellness visit to be done via telehealth and paying for those visits. They are not encouraging the use of self-reported patient vitals, but rather advising offices that a face-to-face visit at a later date may be necessary to obtain the member's vitals. We have been told right now that no audits will be done at this time. Aetna also will pay for a wellness visit to be rendered through telemedicine at this time during the public health emergency. United Healthcare as well. These are ones that we've got confirmation on. And then this morning, Blue Shield has contacted me and let me know that their PPO population and non-capitated Medi-Cal providers, they will actually pay for this as well. Next slide. And with that, I'm going to hand it back to you, Dr. Bittman.
Thank you, Mitzi. And you know, the important thing at this point is that even if you haven't done a lot of annual wellness visits in the past, now's the time to do them. Now's the time to engage that staff or bring back those people who are furloughed and systematically, as I mentioned before, go through your practice and make sure you do this, because this does change outcomes, and this can improve not only the patient's quality of life, but it can also improve your overall practice performance, especially in this current environment. So what we've decided to do is basically give you a rather straightforward workflow. And as you know, if you've heard me speak in the past, workflows are essential to be able to consistently and repeatedly be able to provide high-level service. So our suggestion is that you use your EMR or EHR analytics, find out which patients have chronic conditions in your practice, which patients are on the most medications, refine your patient list, pick the number of patients you want to target. At this time, you may be able to get in far more patients for annual wellness visits than you can when you're fully ramped up and busy. It's important that you reach out to these patients either via email, text, or actually calls. And this is a good time to actually check on them and see how they're doing, especially the ones with chronic conditions or the ones who are at risk. We recommend that you then go ahead and you schedule your annual wellness visit and based on established workflows. And we have an entire presentation focused on telehealth workflows that's available on RCMA docs, a presentation that we've given in the past, which can be really useful for you at this point. I suggest that you mail the HRA or email the HRA to your patients either via the portal or through secure system, and that if at all possible, you ask the patient and their loved ones to complete this before the visit. As mentioned previously, you can actually ask those questions during the visit, but that adds more time. Now, the most important thing here is that I believe every clinician should work at the top of their game. And you do not need a physician to do the entire annual wellness visit. The efficiency of your practices can be predicated on making sure that your other providers, such as nurse practitioners, PAs, medical assistants, can do the majority of the work here to be able to gather what's needed for your annual wellness visit. Next, what you do is you have your physician, your physician provider, or a high-level provider actually discuss and provide a personalized prevention plan. This actually does not have to be a physician, but this has to be under physician direct supervision. What that essentially means, and we've seen this through other presentations, is that the physician has to be either in the office or, in the case of telehealth, readily available. We are recommending, even though this is not a formal part of the annual wellness visit, that you complete an advanced care plan or PULSE. After a discussion with the patient, you can have your staff or yourself fill in the actual form and then mail it to the patient for completion. It's really important that we don't stop looking at advanced directives during this critical period. And finally, and I think this is part of any quality improvement program, follow up with your patients. Survey their level of satisfaction. Ask them what worked and what didn't work, and also ask them if they would suggest that their friends undergo or their families undergo annual wellness visits as well. This is a great way, and I can't emphasize this enough, to connect with your patients. This slide over here essentially shows you the benefits of connecting with MX, Manifest MedX, in the context of understanding which patients are testing positive for COVID. Please realize that the patient you may be speaking with may have actually tested positive for this and you're unaware at this point. So it's important that every provider in the Inland Empire connect up so that you can find out what's going on outside the walls of your practice on your patients. And with that, I'm going to turn this last slide back over to Mitzi.
Okay, so really what I want to talk to you guys about a little bit here is obviously you've got all the contact information on the screen there. The last slide is all the contact information for us. And so I want to make sure that you all understand what the benefits of membership are. If you are a member, if your physicians are members, please make sure that you are using your free member benefits. Work smarter, not harder. We are here to help you with reimbursement, contracting, practice management, practice evaluations, just anything that you could possibly have or need 9 to 5, Monday through Friday. So I want to make sure that you all are doing that. You're paying the dues. Make sure that you're using them, especially right now. We want to make sure that we are there for you. We are trying to give you as much resources and tools to help you and to get you through this time. If you guys are doing annual wellness visits now and you want to transition over and offer the telehealth and you're just a little unsure on how to put that all together, please make sure you give us a call. We're right here to help. So with that, I am going to get the presentation out to everybody today. And if you have any questions, all my contact information will be on there.
Thank you so much, Mitzi. She is a phenomenal resource for all of you. And my suggestion is, if you have any questions, rather than postponing getting into annual wellness visits, please tap into her expertise. She can help greatly. With that, I'm going to ask Dolores if we have any questions through our chat line here.
We do. We have a couple of questions. So the first question, you indicated in the attached form that we should use the as appropriate diagnosis code for well-child telehealth visits. Can we not use the well-child DX code for telehealth visits? By as appropriate, do you mean we should diagnose the visit with the problem that the child might have presented with? What if the child has no problems and is just having a well child visit, what diagnosis should we use for the telehealth visit?
Let me take a stab at it. The annual wellness visit, I do not believe is exactly the same thing as the well child visit. So we're talking about we're talking about a different population and different terminology. So my recommendation in the context of billing for the annual wellness visit is pretty clear. However, for the pediatric wellness visit, my recommendation is that you check with your health plan.
That completed the questions that were posed through chat.
Let me thank you for joining us today. Even if you haven't considered annual visits in the past, and please feel free to contact us in accordance with the contacts on this page. We can help you in many ways on many topics focused on the COVID-19 national health emergency. Thank you and have a wonderful day.